is to continue the discussion about the acid-base balance, the fluid and electrolyte balance. We learned in the previous lecture how to reach a diagnosis regarding acid-base imbalance, and the way to reach a diagnosis is by looking first at the pH in the question or in the case. So if we have a pH that is low, this means that the patient has acidosis. If the pH is high, this means that the patient has alkalosis. The second step is to check the direction of the carbon dioxide. If it is in the same direction, that means that the pH and carbon dioxide are both low, for example. This means that the patient has metabolic problem. If the carbon dioxide is in the opposite direction, let's say the pH is low and the carbon dioxide is high, this means that the patient has respiratory problem. If the condition is metabolic acidosis, we need to calculate the anion gap to narrow down the causes. If the condition is metabolic alkalosis, we need to check the urinary chloride. Now we add additional step, which is to figure out if the condition is compensated or not compensated. As we learned before, if the patient has metabolic problem, the organ that compensates is the lung. And if the patient has respiratory problem, the organ that compensates is the kidney. Now, to be exact and accurate, the way to reach or figure out if there is a compensation or not is by using these formulas: and metabolic acidosis, alkalosis, respiratory alkalosis, and acidosis. But we have an easier approach to reach a diagnosis of compensation. In general, we imagine that we have two kingdoms, the respiratory kingdom and the metabolic kingdom. The king is the pH, and his ministers are the carbon dioxide and bicarbonate. In the respiratory kingdom, the king, the pH, always disagrees, goes in the opposite direction with his ministers, the carbon dioxide and bicarbonate. In the metabolic kingdom, the king always agrees, goes in the same direction with his ministers, the carbon dioxide and bicarbonate. In both kingdoms, the ministers always work together, and if someone is not working, no change in value from normal, then this minister is sick or doesn't know what is going on, uncompensated. So this is a table illustrating how the pH goes in an opposite direction in cases of respiratory problems and goes in the same direction in cases of metabolic problems, as you see. So as there is a faster way to suspect that there is an uncompensated condition, the answer is yes. If the carbon dioxide or the bicarbonate is normal, this pushes us to the suspicion that the condition is uncompensated, and then we can use the formulas to reach an accurate value and figure out if the condition is compensated or uncompensated. So for example, if the case is metabolic acidosis and the lung is not compensating, we might see something similar to this: a low pH with normal carbon dioxide, which in fact in cases in metabolic acidosis, the carbon dioxide should be low. Metabolic alkalosis is the same. If we find a normal carbon dioxide, this means that the lung is not functioning okay. A respiratory acidosis, if we see a normal bicarbonate, this means that the kidney is not functioning normally. Now we come to another subject, which is the regulation of water intake and output. The main organ responsible for regulating water and fluid in general is the hypothalamus through the osmoreceptors. The osmolarity is the concentration of dissolved material present in a fluid. Imagine that you have a cup of coffee, and the cup of coffee contains 1 cube of sugar. This has a certain osmolarity. If the same cup has 2 cubes of sugar, this means that this cup has a higher osmolarity. Dehydration raises osmolarity because it raises the concentration of dissolved materials present in the fluid. And when the blood becomes more concentrated, this triggers the sensation of thirst. Another important factor in the regulation of water intake and output is the antidiuretic hormone. The antidiuretic hormone stops diuresis and conserves the fluid in the body. It also increases reabsorption of the fluid in the kidney. What happens in cases of hyperosmolarity and hypoosmolarity? In cases of hyperosmolarity, as we see here, the cell in general shrinks because the fluid that is inside the cell goes outside the cell to reach an equilibrium. In cases of hypotonic conditions, the cell swells because the fluid goes into the cell to reach an equilibrium, and thus the cell swells. The same happens to the brain cells in cases of hyperosmolarity, as what happens in hypernatremia, and hypoosmolarity, as what happens in hyponatremia. Hypernatremia. If the serum sodium concentration is more than 145 milliequivalent per liter, this is called hypernatremia. The sodium balance in general is controlled by the antidiuretic hormone, the arterial natriuretic peptide, which is produced by the heart, and the aldosterone. The antidiuretic hormone is produced by the pituitary. The aldosterone is produced by the kidney. Examples of conditions that cause hypernatremia are diarrhea, which causes hypovolemic hypernatremia, diabetes insipidus, which causes normal volume but hypernatremia, and excessive saline infusion, which causes hypervolemic hypernatremia. The clinical features are related to the central nervous system and include altered mental status and convulsions. Remember, sodium for central nervous system. Chronic conditions of hypernatremia are often asymptomatic. The treatment of hypernatremia should be very fast and aggressive in cases of acute condition, and careful in cases of chronic conditions. In hyponatremia, the serum sodium concentration is less than 135 milliequivalent per liter. The causes include renal failure, diuretics, burns, water intoxication, for example. Clinical features also mainly related to the central nervous system. Remember, sodium central. Treatment also in conditions of acute hyponatremia. You need to correct this as soon as possible, as fast as possible, as aggressive as possible. In cases of chronic hyponatremia, you need to be careful. Why? Because rapid correction of chronic hyponatremia may cause osmotic demyelination syndrome. Hyperkalemia. The causes may include beta blockers, digoxin, acidosis, some kinds of metabolic acidosis causes hyperkalemia, lysis of blood, which causes pseudohyperkalemia, hyperosmolarity in type 2 diabetes, mellitus, hyperglycemia, and succinylcholine. Hyperkalemia is a serum potassium level of more than 5 milliequivalent per liter. Pathophysiology. Increased potassium concentration leads to the fact that the resting membrane potential becomes less negative, and this increases the excitability of muscles and nerves, especially the heart muscle. So the clinical features are cardiac mainly. Remember, K for cardiac, K for potassium, cardiac. So the patient may have cardiac arrhythmias, muscle paresthesia, for example. Hyperkalemia leads to, if you read an ECG of a patient with hyperkalemia, you will find out that he has a tall T wave. Remember, a pot, potassium, and T wave for T. So, large pot, high T. In hypokalemia, the serum potassium level is less than 3.5 milliequivalent per liter. The causes include vomiting, diarrhea, and laxative. It may be caused by renal tubular acidosis, a condition of metabolic acidosis that is caused by a problem in the renal tubules. Thiazidal loop diuretics also cause hypokalemia. Eating disorders because of repeated vomiting also causes hypokalemia. Here, the decreased potassium leads to resting membrane potential becomes more negative, and this decreases the excitability. Also causes cardiac problems like cardiac arrhythmias. In hypokalemia, the T wave becomes flattened. Remember, no pot, no T. Diabetes mellitus. We have two types. Type 1, which is childhood onset. It peaks at the ages of 4 to 6 years and 10 to 14 years. Type 2, adult onset, typically occurs after the age of 40. The clinical features are almost the same: polyuria, polydipsia, polyphagia. The pathophysiology, however, is different in type 1 from type 2. It is mainly due to autoimmune response with the production of antibodies, autoantibodies in type 1, and these lead to destruction of the insulin-producing cells. While in type 2, it is mainly caused by peripheral insulin resistance. You have a lot of insulin, but the insulin is not functioning normally and resulting in the entry of glucose into the cells, and this results in hyperglycemia. How to reach the diagnosis? So if the patient has a fasting plasma glucose of more than 126, we can say that the patient has diabetes because the normal level should be less than 100. If you do a 2-hour glucose tolerance test and find out that he has more than 200, then this patient is also having diabetes because a healthy patient will have less than 140. Another way is by checking the hemoglobin A1C. If it is more than 6.5, this means that the patient has diabetes, because a healthy person will have less than 5.7. Complications of diabetes are either acute, like diabetic ketoacidosis, hyperosmolar hyperglycemic state in type 2, and hypoglycemia. Chronic complications include diabetic retinopathy, diabetic nephropathy, diabetic neuropathy, and diabetic foot. A practice question. A 20-year-old female in the emergency unit with abdominal pain, repeated vomiting, and altered mental status. So this is a common presentation of patients with type 1 diabetes. They are young, they come with GI symptoms. She has a fruity odor. Fruity odor means that she is producing acetone, and this happens in cases of diabetic ketoacidosis. The lab tests show high potassium, which is very common in patients with diabetic ketoacidosis, and very high glucose level. Please note that even if the patient has high potassium level and the lab tests, the total body potassium is low, because this potassium is the result of an extracellular shift of the potassium from the cells to the blood, and this patient still needs to get potassium with the rest of the medication. What do you expect the acid-base status of this patient? As we mentioned before, we said that a patient with diabetic ketoacidosis will have metabolic acidosis, and this means that the pH is low and the carbon dioxide goes in the same direction, which would be also low. And the bicarbonate and carbon dioxide always follow each other, so the bicarbonate will also be low. So the answer to this question is B. The pH is low, the carbon dioxide is low, and the bicarbonate is low. Thank you.